Stuff.
All right. Thank you, Ashley. Thank you, sponsors. Another exciting night. We've got Dr. Christoforetti back with us again. This is either his second or third time. Second time or third time, Doc? Have you done just the
It's
once?
this is the second time.
Second time. Okay. Yeah. All right. I'm going to get to you in just a minute. Okay.
Yes,
But first
sir.
of all, Rob Manske, Wichita State University, Via Christi. Um, Ashley, Barb, and I were all at the CSM meeting last weekend in Anaheim. Had a great time. And I want to thank everybody who's on that stopped. I had probably 10 people literally stop me and tell me how much they love the Journal Club, which I think is just unbelievable. I think, Ashley, you had people stop you. Barb, I know you had some people stop you too. So thank you for letting us know that. Thank you for watching. I told a couple young ladies I met that I would give them a shout out. So Phil, before you shout out your students, I have to give a shout out to Danielle and Alex. They're from Cedar Sinai Hospital in Los Angeles. And our good friend Barry Schaefer, believe it or not, it's like 4:30 there. So Barry lets them out of work at 4:30 on Wednesdays of Journal Club to watch Journal Club. So thanks for joining us, girls. Phil, you want to introduce yourself real quick?
Sure. Phil Page, professor at Fran U, Baton Rouge, Louisiana, DPT program. Shout out to the Louisiana contingents. I don't see any students on here.
Oh,
Yeah,
no extra
but I
credit.
do see some PTs on here.
All
So
right.
at least a shout out to them. And thanks, Doc, for being here for the second time. And of course, thanks to our sponsors, to Ashley for making this all happen.
All right, Barbara, your turn.
All right, I'm Barb Hoogenboom. I hail from Grand Rapids, Michigan. I'm recently retired from my academic job, but I still do lots of things, lots of stuff. But yeah, thanks to Dr. Christoforetti for being here again and everybody for making this run. To echo Rob's comments, I got a lot of really positive thoughts about Journal Club as well as about IJSPT in terms of citations at CSM and sort of publicity. So keep reading, keep contributing. We really love to have you here on Journal Clubs as well as submitting to the journal. So thank you.
Yeah, thanks everyone. All right, on to our special guest tonight, Dr. Christoforetti. I found some of this out just talking to him just a couple minutes before we started tonight, but he's from Pittsburgh. I knew that. I didn't know he went to University of Notre Dame as an undergraduate. He did medical school training, orthopedic surgery at Georgetown. I just found this out, his fellowship training at the Steadman Hawkins Clinic in South Carolina. Began his practice in Pittsburgh in 2007. I'm looking at your, this is really a nice website you got here, Doc, by the way.
That's great.
Yeah, that's really good. 2019, he went to Dallas Fort Worth, where he joined Texas Health. And in 2023, he returned to Maryland orthopedic specialist. Like I said, he's been on before. He's just a fantastic guy, fantastic surgeon, just fun to hang around. Ashley, are you still on? Ashley, can you tell us just a couple stories about
Oh,
Dr.
well,
Christoforetti? And
we could spend the whole journal club talking stories, but I do want to jump in and just he also
Thanks
recently
for
spent some time in Kyoto with
yeah,
me. Just little old PT me and little old PT Rob Roy Martin. And we took over Kyoto for about 72 hours or so, and had an absolute
You lit up
adventure.
Japan.
Yeah.
lit up Japan,
So
and I
for those that
missed it.
don't know,
Darn it.
ISHA, the International Society of Hip Preservation, Dr. Chris Fetty just finished up his presidency. That was where our annual meeting was last year in 2025. It was fantastic in a number of ways, but definitely the highlight of my trip was spending time with Rob Roy and Dr. Christoforetti in Kyoto a couple days before the meeting. Super like excited for this talk. Obviously, you'll probably hear me talk more on this journal club than any other journal club that we do.
Than any other prior to now.
And he also let me pick the paper. So
I
I
did.
actually selected the paper for tonight and I picked it. One, I always let Phil, Phil can critique the systematic review and whether they did it well or not. But the topic, it doesn't really matter if the paper was well done. The topic is the topic, and that is just like the challenges of this patient population. And I think as PTs, it's just so important to really understand that. And we are oftentimes the first people that identify these patients having hip problems and get them to the right doctors. And that's just so important in the success of their treatment. So I will stop rambling. I'll let Dr.
No, you're fine. That's
Christoforetti
perfect.
jump in
Yeah.
or
So,
drop if you have a first question you want to throw at him or
well,
what.
I was going to just ask, do either of you have it in front of you? Is there any way either one of you could give us just a quick little synopsis of what they did in the paper and what they found?
Okay, well, I hold on. I maximized my screen. Now I can't get out.
So you look for it. I'll tell them.
Okay.
The paper title is "Delays in Diagnosis Are Common Among Hip Preservation Surgical Candidates: A Systematic Review by Morris, looks like Dhillon, Keeter, and Kraeutler. Kraeutler, maybe Matthew
Kraeutler, yeah.
Kraeutler. Thank you.
Yeah, so one of the reasons I picked this is so obviously a systematic review, pretty large, and I of course read this when I picked it and didn't like
Okay.
12
articles.
articles with almost
Yeah.
3,000 hips.
Yeah.
The thing that stands out the most is like we always cite the Closey article, which is from like, gosh, Christo, 2007 or 9.
Yeah, I would say probably more like, yeah, 04.
Yeah, like in the crazy thing is this was done in 2025 and the data is like the same, sadly, that patients are taking,
Yeah.
upwards of it's over a year on average, upwards of 4 years to get properly diagnosed, and they're seeing multiple providers. They're being diagnosed with the wrong things. They're being treated for the wrong things, including surgical interventions. And it's just the crazy thing about this. The thing that stood out to me is I was like, oh my gosh, like I feel like we've made so much progress, but the paper is kind of saying that we're in the same boat. So
Yeah, I'm guessing, Doc. So I guess that's the first question. What is this? Is what the paper's describing? Like Ashley said, she didn't feel like that's like actually how it is every patient she's seen. Is it? There's got to be like pockets of areas that are better than others at treating these diagnoses and finding people quicker. But when you look at this study, 12 articles, almost 3,000 hips, that's a lot. Maybe it's still the same, but you got little areas where people are better.
Yeah, I mean, well, look, first of all, hello, everybody, and thank you for the kind introductions, compliments on the website, for the invitation back, and if, Ashley isn't making it up. We had such a great time in Kyoto. We talked about the life and the philosophy of life, and we enjoyed being in really this ancient, amazing cultural epicenter, and I think that when we were there, and whether we're on this journal club, or at your team concept, when I met many of you, look, the dialogues like these are what has made a difference. And I want to say that the article isn't true, because I just think that there's probably a greater awareness in the different types of diagnoses that were being met. We were seeing in the early 2000s GI surgeries, GYN surgeries, extensive psychiatric damage from frankly just patients with somewhat of a Cassandra complex, where they've been telling people and telling people and telling people, and then the trust had broken down. And I'm not suggesting that doesn't still happen, as the article does seem to indicate there's delays. My feeling is that at the time it was just hip diagnosis in general 20 years ago. And now we're looking carefully with this systematic review with this concept of hip preservation, which, back in 99 to 2000, you'd have to be in Bern, Switzerland, or with Jeff Mast in Reno in order to figure out what the origins of these preservation concepts outside of a pediatric setting. And I think that's the main thing to remember is honestly that this probably tells us still there's a huge transfer of the baton failure. This is just an opinion. I'll let you guys rattle it out, but I'll never forget being at AI DuPont Institute for Children for 4 months. Like right after my son was born, I left my poor wife and went there for 4 months. And that was my first experience with full-on musculoskeletal pediatric orthopedics and multidisciplinary care for the child. And what struck me back then in 2005 was all of these hip osteotomies, all of these different things done for cerebral palsy and or DDH, which were being referred to a world center like DuPont, And then I'm remembering what it's like at the time in the Washington, D.C. area, very big area where we were working. And there's just this drop off at that time. You had scoliosis clinics, you had hip CP clinics, you had limb length discrepancy or growth clinics, you had dwarfing clinics, but and then it stops at age 21. And we would look at things like femoral antetorsion, and we would look at in-towing. And there were norms and normative things that were being said on the old disciplines, the surgeons, the PTs. Well, this degree is what's abnormal, this degree is what's normal, and it will be fine if it's not. And we're making very extreme recommendations. But what we didn't have is this awareness that these things that we thought were normal femoral rotatory deformities, and these things that we thought were just going to be self-resolving neuromuscular features in teenagers, could potentially be connected with high rates of osteoarthrosis in the adult outside of, these certain pockets. So my feeling on it is that we were still at, as orthopedic surgeons, arthritis, bursitis, and fracture. And I believe we did really skip over when this new systematic review is done. We're missing middle 10 years where everything was a labrum tear. And I think what they're looking back now is they're looking at the concepts of femoral rotatory malalignment and or other kinds of more complicated surgical radiological features or range of motion gait-based features that we're now looking at in the setting of known soft tissue problems. Like we may have someone that's had a labrum tear misdiagnosed for hip preservation concepts in these cohorts of patients for years. They may even have had hip labrum surgeries done and still be in delay diagnosis categories. So that's where I'm thinking the missing link. I don't know, Ashley, if that jumped out at you too, but I don't think all your good work has been to nothing. I just think it got more complex real quickly.
Yeah.
And we had this, and now we're seeing that waterfall of an intensely magnified cultural global expansion of youth repetitive sports, of a Gatorade commercial style quest for excellence in sports at younger ages. And we're seeing a narrower gate of physical performance than ever, that potentially back then was ballet, martial art, maybe diving. You would have figure skating. You would have very few sports that were so draconian in exactly the form of how things have been done, pitching. But now we see a commoditization of appropriate sport form without global awareness of these hip rotatory concepts. And we may be seeing another bloom where we're learning the difference between, these rotatory conflicts of motion and or whatever we want to call them, and the diagnoses. But it's going to happen faster than you could think. But I mean, it really was 12 articles. There have been like 1,000 articles.
Yeah.
So that's the other thing I wanted to know about from you guys. Like when I read this, I'm like, were y'all going to say this is bad? This is kind of poor science. Like they just only wanted to read 12 articles, so they excluded everything. Like that's what I wonder. What do you think, Barb?
That's why I leave it to Barb and Phil to handle that
Yeah,
part.
Barb and Phil.
So the first thing I notice is that there's one level 2 study, one level 3 study, and 10 level 4 studies, which tells me that either they excluded so much that they've got a lot of level 4 evidence, and they ended up categorizing this systematic review as level 4, which is, okay, I'm just sorry to say this badly, but, crap in, crap out kind of a thing.
There you go.
So it's kind of a, you see that either, to your point, Dr. Christoforetti, that they either excluded a lot of stuff or they were very narrow in their inclusion, and they may have seen only the window that they chose to see. Does that make sense? Phil, what do you think?
Yeah. No, I agree. I was looking at the list of 12, and I mean it's pretty. Now the problem is it would be hard to do an RCT level 1 study of delay, right? Because then you're bringing in, you're bringing in the delay, which is unethical, theoretically.
True.
So to limit it to level 4 studies is fine, level 3, whatever. But I think, Ashley, you had said earlier that, things aren't changing, that you thought things were getting better. I was looking at the references that these authors were talking about of previous systematic reviews were all done 24 and 25, 23. And this is
Mhm.
25. There's only one study additional in 2025 that this systematic review included. So it's not that it hasn't changed, it's just the same. They're reporting the same stuff. I mean, you've got three
Mhm.
studies that they reported that they have already done on systematic reviews. It's all saying the same stuff. And it's not going to, I agree. I loved this learning from this because to learn more about what hip preservation was great to me. I
Mhm.
thought hip preservation was people that are really messed up and you've got to fix them. I didn't realize how you were including FAI, hip dysplasia, femoral torsion.
Mhm.
That was eye-opening to me.
Mhm.
And that really changed the game for me. And ironically, I'm teaching hip biomechanics tomorrow to my first
Hey,
years.
there you go.
So I'm going to use
Go
Perfect
this.
timing.
Phil.
Perfect timing.
Well, we have a broad panel. I don't want to dominate it. I'm just thinking, like, keep in mind that I agree with you. This is, look, with AI, and it's always the elephant in the room. We with AI, what we're having is this uber sampling large language model ability that it's going to replicate and it's going to fabricate and it's going to do these things. So we're looking for these human-based interfaces like a systematic review, where the human decision-making team of writers is precisely not the artificial intelligence, so to speak.
Mhm.
When with Ashley, I think you're even thinking maybe even further back to, like, Thomas's original work that you all did when we're talking about, like, late 90s, early 2000s, to try to get
Mhm.
thinking about the diagnosis of intra-articular pathology, because again, that old day of just not knowing how to diagnose, particularly on the surgical end. And then on the flip side, the frustration of physical therapists and or movement specialists with just this languishing group of people that is not able to soar the same way that the knee and shoulder patients are able
Mhm.
to soar, or honestly, quite worse, applying decades of well done knowledge about the patellofemoral joint in the setting of athletes that we are not aware associated with the way the proximal femur develops in mated distortion. And
Mhm.
now we have massive amounts of information that's super healthy for the well tracking patella that could potentially contribute to these insidious soft tissue problems that would often be that tip of the iceberg labrum tear. That's that tip of the iceberg snapping hip, or that tip of the iceberg person who's got deep buttock pain, God forbid. And you're looking at those areas. So, but I'm going to tell you that, there are very few things that we've had a chance, I would say, to live directly through and see every contributor to it. And I've been a part of seeing this. And what all of us have seen is the beginning of email. We've seen the beginning of, like, CDs. We've seen now the beginning of AI. So we're in a generation that's seen humongous paradigm that's rolled out in front of all of us. Humongous paradigm. And so we're obviously conditioned to adopt new things. And if we weren't adopting new things, we would unfortunately not be able to succeed in this world. So what we see then is a tendency to potentially rapidly adopt new things. And that's what I think makes it stand out the most, that we don't see the rapid adoption of these concepts now versus 20 years ago, when the paradigm of internet, paradigm of social media, it hadn't really blossomed yet. It was blossoming, but it hadn't when hip preservation first hit the scene. And now when I look at this paper, I think, and again, geez, you say, what do we do with it? What do we do with it? And we know that for the majority of us practicing in clinical practice and physical therapy and orthopedics, and certainly with teams, it's the symptom of pain and the dysfunction of pain that is what we're after, because that's what our patients are bringing to us. And then when we've not had the symptom pain and the function loss of pain be successfully working, then we may look at tissue damage as a result, right? Maybe something's damaged. But now what it's asking us to do is see, does the global musculoskeletal community of either therapists or surgeons have the time? Do they have the economic support? And do they have the knowledge to perform movement-based assessments and range motion assessments in a context? And I know that that is not common. So it may be that what's also not changing is that the forum for detailed evaluation in real world application of medicine, unfortunately, as our sophistication has increased, our time allotment, our economic allotment, and the expectation that we're doing is shrinking. So we're asking for broader and broader awareness points at the same time as we have less and less time that's being allocated.
Yeah.
So
Yeah.
Yeah.
And we had that like that's actually a conversation we had in Japan was I think and it's not like we're the only practice that does it the way we do it, but we are definitely abnormal when it comes to how we practice evaluation of these patients. I mean, a patient comes to our office for evaluation of their hip and they are with us and like physically with us for someone at any point in time for upwards of like 2 or 3 hours in their time with us. So between their therapy time, their time with Dr. Bird, their time with Beth, our nurse practitioner, and then maybe the therapist again, and their imaging time, like we tell them like plan to be here for the day. And like in that day, they have probably at least 2 hours of contact time to some degree. And that's what allows us to and the diagnostic injection process and the testing them before and after is how we are able to kind of suss out these very particular things. And especially now getting to the side of like, okay, now we became more aware of FAI and labral pathologies. And then a lot of people started doing FAI and labral surgeries. And now in our practice, it went from when I started with Dr. Bird almost 12 years ago, it was a bunch of people that got told they were crazy and that their hip was not a problem. And then we were figuring out, no, your hip is a problem, to now it's some of that.
Maybe it is a problem.
And then they've had a hip surgery.
Yeah,
they've had 2 or 3 hip surgeries and they still have a problem. And now they're being told, well, it's not your hip and then you're crazy and you just need to get over it. And it's because, well, yeah, they had a labral tear, but they also had a femoral rotational problem that got missed. Or, there's all these just like it's not just FAI. It's not just a labral tear. It's a lot of 3-dimensional anatomy that it's like, okay, we got the first piece. We realized that it's not only arthritis or bursitis. There's the labrum and there's FAI. But now it's not just FAI and labrum and bursitis and OA. It's femoral rotations and acetabular dysplasia and all these different things that can get missed. So we're still like, to your point, like we are all still learning about it. But our time to spend with patients seems to be decreasing.
That John, that made me think of something when you were talking about that. Are we like in the hip? We're really behind what we are in like the knee and shoulder. So you were talking about this massive information that we've gained lately, but it's almost like I don't know how many years. I mean, how many years are we behind in the hip than we are in the knee and shoulder? I mean, we know so much about the knee and shoulder, and we're really, like Ashley's saying, we're still finding out. And of course, we're finding out new stuff in the shoulder and knee, but it seems like the amount of information that we're dealing with and finding in the hip seems to be more than what's coming out in knee and shoulder, almost like we're 10, 15 years behind or something.
Yeah, I mean, I guess if we knew the endpoint, we could measure it. But I think that the biggest thing, well, look, here's a paradox. And I think this is an interesting one too. We're going to strive to naturally focus on the challenge areas, especially when we're looking at a paper that's pointing out an obvious blind side.
Yeah.
And we should. And that's what drives it forward. But if you really take a look hardcore, because I do perform surgery in these other joints, the reality of it is all the literature about having your hip labrum fixed and the return to sport rates are superior, and the durability is superior to the majority of what's published in the shoulder for the corresponding labral tear. In addition, the expectation at the levels of sport that we've talked with, at any of the teams I've been involved with or any independent consultation we're dealing with, we look at ACL re-injury rates and we're looking at the rash of information, looking back at what we thought we knew. We're obviously just I think it's like anything else. You peel the onion, you peel the layer, you learn more. And that's where progress is coming from. If you ask me, I think that the knee surgeons that are now being reheard with the LET, and that were being potentially reheard with tibial slope, and maybe they're being reheard on the unicompartmental, these sort of surgical extreme examples, which I hate to say extreme, but even as a surgeon, to me, activity-based populations surgeries are not the first line of things that we do. And when we look at these areas, so we look at these areas, though, the knee a long time ago, it's been very difficult to talk in the United States, globally, maybe a little different perspective, but a high tibial osteotomy is an eye bug out of your head moment. Okay. When we look at dealing with rotator cuff disease with a reverse arthroplasty, that's a pretty big hammer. So, I think that there are some areas where we have advances. However, the science of tendon to bone healing is better understood. The basic science of ligamentization and or cartilage changes at the basic science of the knee is much, much better understood than what we know about with our hip. The radiological consequences long-term of the soft tissues we've operated on in patients doing well and in patients doing poorly, we're light years behind. We haven't had clinical equipoise to randomize things like a hamstring or a BTB graft like you've seen here at IJSPT do. So we have at least a pre-AI decade of traditional scientific research that we're behind. Okay, but I'm saying we are in a post-AI epoch, and we're also at an era where we are now having a more comprehensive than ever look in all joints, or if not a relook, where the joints are informing one another. And I'm going to tell you that it was the hip arthroscopy that was arthroscopy first, because we didn't have an open surgery, that drove our awareness of greater intra-articular problems, greater articular problems in patterns, those patterns then correlating with symptoms. And in the same parallel universe, you had the quest to not have your hip become arthritic, which is the origins of hip preservation. That's separate from what is my athlete feeling. That was not the same thing. These are largely trauma and pediatric surgical colleagues that are genius, brilliant technicians, geniuses, and moving skeletal cuts to change the biomechanics to delay articular cartilage loss and eventual arthroplasty. That is not the same as what Drs. Bird and Philippon and McCarthy were doing, Viller. These are athlete serving practices. So this where I run in a lineage of sports surgeons that do hips, and we have to think about these preservation concepts that we would have had to draw back to pediatrics or back to severe trauma. So my feeling on it is, are we behind? Well, we're probably the only field that had to grow up in a modern era where the comprehensive expectation is that outcomes will be tracked, is that the science actually matches, that the resources to do the surgery are limited, and that physical therapy itself would be called into question by insurers after your operations. So that's been the crucible that the hip has had to come up within. You'll be surprised, and you'll probably remember this, guys. Brian Kelly had to give a talk at AOSSM probably, I was in New Orleans, it must have been in 2010-ish. Is the hip an athletic joint? That was the main stage at the specialty for the AOSSM and ATA. So, that ain't that long ago. So, I think we were pretty sure that the knee and the shoulder were athletic joints, like in the first Olympics. So we didn't know.
We should have known that about the hip too. Yeah,
so
that's
right. Where I think that we are a little bit behind. But I would say that in a trending manner on the surgery end, the people of us that are currently like on the other side of half midway through our careers, God willing, when we were trained, most of us with either Hawkins or Russ Warren, or we trained out and we were commissioned by or trained out in Birmingham, and say, you've got to be the one to pick this up. And that's been basically 2005 till now. And as a result, we had so much support from you all as a community, from Pete and Rob and Ashley, and we have this support that's coming in, and And that was super unique. And then we also at the same time had massive industry support because it was the potential for this new field where surgeries could be made. So we did get a turbo injector boost on the procedural end. And that led to Ashley's comment concerning what we do see a bit of now.
Yeah,
Which
what drives
is surgical revision rates that have gone through the roof. And we know we had those, by the way, in the Gore-Tex ACL, and we had those in slap repairs, and we've had those in patellofemoral surgery. So we've had our own learning curve in the hip, and I think, and that's also where we are now, is that we have widespread adoption. It would be very rare for me to imagine that this article could be accurate, considering the sheer number of arthroscopy is being done in this country.
Yeah, yeah.
I mean,
I can tell you,
there's that many arthroscopies done in Nashville this year, just with the people, like
Right.
between all of us that are
Right.
doing it.
I can tell you that
Go ahead,
there's
Phil. Sorry.
a lot of good research that's come up in the past few years about the hip because of what you guys have done, Doc, and you know, Rob Roy and Ash and everybody in Keelan. The hip group has just escalated the amount of knowledge that we have on the hip, to where, as an old sports medicine guy, I didn't really appreciate the hip as much as I do now. And this morning, I had a first year come to me, and I'm like, we're going to talk about the hip. You thought the shoulder was bad. Wait till you talk about the hip, because we have learned so much in the past few years about the hip. To me, it blows the shoulder away. I am so intrigued by the hip because of the research that these guys have done. That's the other part of this, is not just in the surgery part of it, but in the rehab. And kudos to you, Ash, and Mike, and everybody at TOA. You guys have done a fantastic job. I appreciate it.
Yeah.
Can I jump in real quick?
Please do.
Of course, Barbara.
One of the things I've been thinking about is, like, you know, we talk about the knee and the shoulder so much, but think about the hip in terms of its movement capacity as a central body joint in gait, in normal function, squatting down to sit down in your chair or your toilet. And it's one of those things that I think that we have underemphasized sometimes, the movement capacity of the hip in terms of if it's not functioning well. And it's so important for us to think about patient satisfaction, patient outcomes, and movement as a big construct. Again, I want to give a quick shout out to Shirley Sarman, who's on right now. And Shirley, I mean, you
Shout out,
taught
Shirley.
me, you taught us all so much about the movement system, about movement. For years, we ignored what the hip had to do with simple movements such as gait, squatting, getting down from a floor, or up from a floor, down to a floor. And so again, I think that part of this is this coming of age of, like, okay, this is a big deal. And it's not all in people's heads. If they can't tie their shoes, they can't get their pants on, they can't go to the bathroom. It's like, that's a big deal. So I was just thinking about that in terms of, like, a little bigger picture thinking.
No, you're so
Barbara,
right on. You can't put your, look, there's so many different ways that we've been able to learn from, as surgeons, what y'all are doing, like just even the term functional rehab, which we learned to say, what about functional rehabilitation? What exercises can they do? Can you please give me a sheet of home exercises, or can we just do this? And you learn about, but and listen, in the hip, like you're saying about standing, you can't put your hip up and rest it. You can't just like I can stick my shoulder in the sling, I can put my foot up and rest my feet. These patients that are dealing with the central athletic pivot in their life, and it's dysfunctional, it never goes away from them. And
Absolutely.
It's always a problem for them, and it's always there. And it is really shocking. Every time I move, I'm not moving anymore, but every time I move, I meet so many new great physical therapists, and I get to see the tone of the region and what the regional kind of strengths and weaknesses and awarenesses are in these areas of the country that I've been. And I would say that within a year or two of me getting to a different location with the practice that we bring to support physical therapy, because we just don't do surgery if someone hasn't had physical therapy, the number of questions that come in and trying to distinguish rehab from the ACL, from rehab from the hip. And I really feel like at its core heart is going to be that critical, like we had to go in the surgical community. We have a lot of heavy work to do this between arthritis, bursitis, tendonitis, and what about preservation? I really feel like that's still where an awareness piece I would love to see done would be in the therapy world. How much does Russian stim of the quad matter to hip rehab? And how much does, and because I don't believe that it does. And I think in the same deal, this is just where we're seeing like the surgeons use their same tricks. It's been the hip group that has made changes over these years in your community where I see therapists very aware now in ways they weren't 20 years ago because they were just hands tied, looking at stretching people into FAI ranges, stretching people into these areas to try to get those soft tissues that were tight loose, but it's pushing that bone into an area of conflict. And now I see it's very rare. So you guys have done an incredible job in my mind of getting that out there. And I don't think that that's as static as what this paper is showing. It may be that this paper is selecting something, but I'm seeing that the PTs are if anything quite ahead of that, of where they've been on that. I don't know if you are seeing that, at your combined sections you went there, but I feel you've made an impact.
Hey, Ashley, regarding this paper, can you go over, like you said, there's obviously people are misdiagnosed, probably misdiagnosed by therapists and physicians. What are some of the more common misdiagnoses you see with people that end up going this route?
Yeah, I mean, I think it just depends on what the age patient population. So I'll do the easy ones, like your older adult population, particularly women, but just general older adult. If they have any pain on their lateral hip, it's bursitis, right? It's bursitis.
Always.
And God forbid if it goes down their leg in any way, shape, or form, then they have sciatica, right? So bursitis and sciatica, and it's and they've literally been injected blindly in their, bursa 57 times over the last 10 years. And what do you know? It's not helping. So that's the low hanging fruit. Unlike the more athletic population, it's everything from, it's definitely your spine, and it's not your hip.
That's a whole nother topic. That's a whole nother
and obviously there's a lot. When we can talk about hip spine syndrome, we're not going to go down that rabbit hole right now, but hip spine is a thing and they're related. But then SI joint is a big one, and it's not as we went through a little blip, and it could be just totally random, obviously, but we saw a bunch of SI fusions on these patients, which is terrifying, because that's once you do that, I don't know how to help you.
Any fusion.
It's the beginning of the end of movement, but go ahead.
Yeah. So SI joint and low back, I would just kind of lump that together. But and then your tip, it's you have a hip flexor strain or you have a groin strain, and you see that a lot in the athletic population. And while those can overlap, particularly in Christo sees a lot of this too, but in your hockey population or those they've had chronic groin strains. Okay. As soon as I see that in the history, I'm their joint has to have some sort of issue, right? So those would probably be the most popular. And then you can get into the weird stuff like Christoforetti was talking about, OBGYN issues. I mean, I've had females who have had total hysterectomies in their 30s because they found some random cyst on their ovaries and were like, well, that's where your pain's coming from. We got to take it out. That's extreme, but I've personally sat in a room and had females cry and I can't believe that I didn't find this out before I did that type of thing, which is terrible. And then, exploratory abdominal surgeries. And the classic, you have fibromyalgia, of course.
I hate that one.
You just hurt everywhere. Yeah. So I do think we're getting better, to my earlier statement. And I think obviously we've pointed out the challenges of this paper. I think we've gotten better, but I also think we have we've just had an explosion of information in a very short period of time. And it's like everyone's trying to like filter out like, what do we do with it? The surgeons are going to operate it on it. The therapists are going to try to rehab it. And then like, hopefully we do something good in the middle.
Yeah. Well, so there's I mean, if well, I get Mike, I want to ask this question, but I'm not sure how to ask it. So what the hell are we supposed to do? Okay, so we've got a patient who comes in with hip problems. We're seeing them obviously based on this paper. Number one, we may not know what's going on, but even when we refer them on to the therapist, I'm sorry, to the surgeon, sometimes that surgeon or the doctor doesn't know what's going on, so it's passed on to person. What's the ultimate goal here? What should this, in the perfect world, patient A comes in with a hip problem to see Ashley. What should happen? I mean, what do we want to see?
Only Ashley can answer that. I mean, I'm not gonna answer what would be perfect for you. That would be, hey, we brought the surgeon on to mansplain something for Ashley.
I mean, again, like I live in a very special world where I practice, and the fact that I get to evaluate a patient, I get to have Dr. Bird look at their imaging, go over that with me.
Time out for just a second. I have a question for you. Do you see every patient the same day Dr. Bird sees? I mean, so if Dr. Bird sees a new patient,
I don't
do you
see all
them?
of them.
No. But a therapist always sees them if they see Dr. Bird, or is it if they see you, they also go see Dr. Bird, or like vice versa?
If someone's coming for Dr. Bird's opinion on their hip, they always see a physical therapist.
Okay.
Myself or one of my team, and honestly, more often one of my team at this point because I've taken on too many roles. But they see us, they see Dr. Bird, he goes over their imaging, he goes over his thoughts on their imaging with us. We powwow on what's going on. And thank God for technology. We powwow via Microsoft Teams between the walls instead of having to stop what we're doing and walk over to clinic these days, right? But we communicate about it. And then we have Beth Bardowski, who is our nurse practitioner, who does diagnostic ultrasound guided injections. And we can say, hey, like we think it's their joint, and we can stick numbing medicine in their joint. And sure enough, all their pain goes away. And we're like, okay, confirmed. They have a joint problem. And Dr. Bird's looked at their imaging and he thinks like this is their specific joint problem. And then we can go from there, or we can rule it out, or we can figure out that it's a piece of the puzzle, but it's not the whole thing. And so obviously that's a perfect little world we live in. In the real world, in the big picture, like that's
99.9% of us don't have that.
And that's not the way orthopedics is going, right? So like in the real world, and this is what I tell the therapists when I talk to them, and I think some of our students are on here, is like what the therapists need to get good at is making sure you know like what's going on in your patient's schedule. Like, are they scheduled to see the doctor? Are they scheduled for imaging? Are they scheduled for an injection? And particularly if they're scheduled for an injection, help educate your patient and empower them to know like what are they getting injected and where, and then know like that they need to take that opportunity if there's numbing medicine involved, which is a diagnostic procedure, that they know that they need to move around in the ways that normally hurt them before that injection, and then do that after, even if they aren't asked to by the provider. And particularly in instances where they're doing things under fluoroscopy instead of ultrasound, and they're having to go into a radiology department and all of that, they're not even probably anywhere near a provider that knows them. So that's where I think from a therapist perspective, and it takes a little bit extra effort, but it goes a long way to just empower the patient to understand like why are they even doing this? It's not just to, oh, I'm getting an injection. Like in the patient's mind, I'm getting an injection, it's going to make me feel better. That's great. I really hope it does. I really do. But more importantly, I want to know like, are they putting any numbing medicine in there for you? And can we get some diagnostic yield out of that experience? And we spend so much more time with our patients than the doctors do that like we can be the people that help them understand that.
So Ash, I just want to quick jump into it. So you say that you operate in a very cool world. How much time do you think the average PT can do some of those things? And are we educated enough to educate like that? So when you said, they're going to go see Ashley, what did we say? And Dr. Christoforetti said, well, I'm not going to mansplain it. I'm like, I'm glad they went to see Ashley and they didn't come to see Barb because Ashley knows more than Barb.
Yeah.
So, that's
Right.
part of this whole game, isn't it? It's clinical
Right.
expertise, and
Yeah.
it's supported practice that knows enough, or you as a practitioner, me, know enough to say that's not my area of specialty.
Mm.
This is very wise, and I appreciate everything Ashley just said, because it is um, in centers where we are concentrating the patient stories, and then
Right?
we're observing for those patient stories. You can instruct, learn, and teach. When you
Hmm.
have rare encounters with small numbers, it becomes very difficult to instruct, as we all know, about anything.
Hmm.
Um,
Hmm.
you know, from a surgeon's vantage point, I'm just going to tell you, I'm doing a surgery this week coming up where I'll be putting 3 screws across a stress fracture in a 17-year-old who has been in rehab for 9 weeks as an endurance athlete with a complete femoral neck fracture treated as a hip flexor strain. And I think that we need to remember that hip preservation is a set of diagnoses that are part, but not nearly all, of what you can capture. And no orthopedic surgeon, primary care physician, chiropractor, or therapist can adequately diagnose these problems that are possible, and they'll bite you. So my feeling is weight-bearing pain equals referral to one of us that can order radiographs. If we have someone lying on their table and you just gently log roll their leg and they're jumping off the table, you refer them and you establish a relationship with one of us. I'm here to tell you, if any of us actually understand any of the words in that preservation paper, we are not jumping at the bit to try to operate on everybody. That is not how it works. And what we really want is to have an opportunity for these type of conversations. And then you will learn very quickly because you're working together. But when you send that patient, the message that I would love to receive, if I could, from as many referrals as we get: Doc, I have more I can do. I'm just checking for the x-rays or the MRI. Or, Doc, I'm at my wit's end. This patient has had it. I need you to help me figure some other reason why I can't work it out, because I don't know the context of that referral if I'm not having that be within, whether it's one of you all that I'm always working with. So
Yeah.
if you tell us,
Yeah.
then we know. And you're always going to get that patient back to do what you think you can do with it. Because from my end, I'm like, great, you got something you can do with it still. I'm going to tell you they've got, what grade of arthritis do they have? We're gonna get MRIs to be able to order and source those to make sure they don't have these AVN, stress injuries, tumors, these hidden ovarian problems that actually do exist sometimes, and when they do, there are problems. We can screen with these studies, and this is part of the silliness of your insurers saying they need 6 weeks of therapy to qualify for studies. And then what it does is it makes the patient lose faith. You all are using up your precious time in your visits, and we don't have the imaging we need to give you a very specific tissue and structural framework to work within. So in my world, Rob, it would be they see the PTs at direct access, which is where they get the most of their trust. They're really aware that anywhere between, basically the sternum and the middle of their thigh, they may not fully understand, right? And if they're limping, they don't have a log roll, and that individual is having symptoms for longer than a day or two, they got to have a good relationship established, or you shouldn't take those walk-ins.
And
Those walk-ins are going to bite you. So that's sort of where I would view it. And then once it goes from there, sometimes that patient swore they were told they had no arthritis. You're going to get a call back from me and says, dang, look at this x-ray. And here's one thing we should, because I know it's getting late. You know what else has changed in our timeline? The polyethylene used to replace a hip had a 8 to 10 year survivorship when you got it under the age of 50 when I started working. That's 20 years.
now,
And now
Now.
projected survivorship is over 25 years.
Nice.
So when you see that, and that made a huge difference in the flow of arthroplasty.
Mhm.
So we've seen some things change right now. There's still a role for everything we do, but instead of having to apply that role universally to everyone that used to be mysterious, we have now got this into a region where we need to identify together as therapists and surgeon teams non-arthritic hips that have failed the ability to overcome their structural limits to achieve normal movement and muscular balance to get what they want. And if we don't understand the structure in the arthritic grade, I'm not clear on how we're going to have to ask you guys to get them to the other place. So we have to give you that information, and then we work together. And I think that's what Ashley's mocking. And the injections, when we have them do, guess what? Check every box, and they've got something wrong with every part. Then we have to go through and we have to make these differentials. And Rob, remember your question about how far behind we were?
Mm-hmm.
Remember Dr. Hawkins and Neer, they have the Neer sign,
Uh-huh.
and they have the Hawkins sign.
Yep.
Remember that the language was the Neer test and the Hawkins test. And that's in all the literature. And that was a ouch, numbing, doesn't hurt anymore,
No ouch. Yep.
positive test. So we're going back to those areas when we had, legends like that tell us early on to help do this, like Thomas Bird and others. So that's sort of where I think, that would be my dream, would be that we knew we had no limp, fine, no log roll, fine. Give yourself a time limit. I would think it should be 4 weeks. I don't know what you think, Ashley, but I think if you're not seeing meaningful progress in the hip area in 4 weeks, get them to a doc, get them the film, take them back, but send them with a message, send them back to me or get them to someone else. Like that would be so great. And I don't know that we always do that.
No, but those, I appreciate you saying that, because those are the kind of pearls that I think people on this want to hear. I mean, just stuff like that where I think we kind of know that, if someone's limping and they can't walk without it hurting for a while, we probably should send them. And if you're doing the log roll, which really shouldn't hurt and it hurts, we probably need to send them. But having someone like you reiterate that to all of us, I think is a couple unbelievable pearls. So for everyone watching, those are just some great tips.
Well, and
Ashley, you had
I have like
some.
a small thing on that because we literally just had this conversation last night. So I apologize to my residents who are on here and heard it last night as well. But like, I think sometimes as therapists and maybe doctors do this too, but as therapists, we like feel like we can like rehab everyone to success. Like we just get this like bee in our bonnet. Like I got to fix this person. I got to make him better.
I can.
And like,
I can.
and like we grasp at straws almost like, well, they're a little bit better. So like I want to keep trying. And I just had like the trainer that works with me at my gym. He was like, can I ask you a question about like a new client I have? I was like, sure, whatever. And he was telling me this whole situation, and she's been in therapy for 3 or 4 months. And like she's some better, and the therapist like emailed him and said like, well, her range of motion's better, but like she has weight, like she can't walk without a limp. She can't like advance her leg forward, and she's been diagnosed, like her diagnosis is, iliopsoas tendinopathy or something. And I was like, sounds like she needs a hip replacement. I was like, how old is this woman? When does it hurt? Whatever. And I was like, sounds like she might need a hip replacement. Tell her to go get an X-ray. And so he saw me and he pulled me aside in the gym the other day. He's like, my lady? I was like, yeah. He's like, she went to the doctor. She needs a new joint. And I was like, yeah, I'm like 3 to 4 months of physical therapy and you've only made a little bit of progress. Like I know we love our people and they love us, but I think sometimes we let that go a little bit too far. Not because we're trying to make more money off of insurance providers or whatever. It's like we build this bond with someone and they trust us and they're like, no, I know you can get me better. Sometimes we have to like lay the law down and be like, I'm not getting you better. Like,
And totally agree, Ashley. Bottom line is we think it's almost a failure if we
Right.
don't get someone better.
Yeah.
It's like there's a time where you call it and you say, this is not going forward, or this is not going to the place where you need to be.
Yep. And that's like I spend so much more time mentoring like my residents and the younger therapists on like those types of things. Like when do you just say like, this is this is not a thing I can do. And the best way to help this patient in front of me is to get them to the right person who can help them, whether that's a Christoforetti or a joint replacement guy or a different medical provider. And
I mean, it could also be, and honest to God, and this is just, we could go, well, we could walk through the streets of Kyoto for 2 days and talk about it. The reality of it is like the person that has not been mentioned is the mental health professional, because the other element that I've seen occur has been that two-edged sort of referral and knowing your limits, where we see that the hip takes longer. And if you're depending on your economic structure and what you have going on, no good deed goes unpunished was the Georgetown statement, and in the end of the day, if you get good at taking care of things that take twice as long as everyone else and you get sent all that stuff, you often have challenges. So you need to really, I think it really does take a self-awareness to understand what are you looking to do within this joint, what kind of population you're looking to serve, and you develop like you all do very well in your other ends, you develop some screenings, a good example, Neil Ranawat published a nice study that it's just watching their gait. If you're seeing out towing, during gait, they were able to correlate that. We've written about the single squat that Rob and Brian McGovern did, which all kinds of squats that are there. You have things that y'all can look at pretty quick to decide what's happening. And you have your screenings that the therapy community led the world in the PROs. And, I mean, you just simply did. And so you have ways that you can put these screenings in place. But I know so many different PTs that it's just so many of you all that your settings are very uniquely different in how you do and what your team support's like. Here in our practice, here we have Eastern Germain and his team, and they do a wonderful job for, taking care of team style, team concept, and some of you that are that intense one-on-one concept. But the key is if you don't fit your referral screenings to preserve yourselves and to preserve that the most high impact time with the patient, which I still feel the best of you, the clearer you understand the problem, the faster you all are able to make that person well. The more time you've got to spend wandering around figuring the problem out, the more difficult it is. And so loading the boat with imaging and loading the boat with that and that clarity in the hip is going to really, really help take the fear of it down, just like it would, but guess what? If someone has a rotator cuff, it doesn't solve all of their problems in the world, does it? So you need to pick, and I saw Brian Graham put a comment on his threads. Yeah, you got to figure out who you're working with.
Yeah.
Absolutely.
Yeah, I think, and that goes to I think we end up having a lot of these conversations in the hip world by nature of everything we've talked about for the last hour. But again, know where your strengths are and then build your team around you. Like the moment I get a referral for a foot and ankle problem, I'm picking up the phone and I'm calling Chris Wolf and I'm booting him down the street to him. Because that is not
your specialty.
That is not my specialty. That is not my strong suit. And there's a need for great, awesome general orthopedic physical therapists, and we can treat a really huge chunk of the people. But then you get some of these outlier situations, some of these patients we're talking about, or some more complex shoulder, foot, and ankle. I think a strength of a really good clinician, period, doesn't matter, doctor, therapist, whatever, is when you're outside your zone,
for sure,
and when to ask for help.
Yep.
Great point.
Yep.
So
hey, before we go to the paper, can I or not the paper, the next section, I want to give a shout out to Amir.
Yeah,
Amir.
Yeah, hi Amir.
It's like what time is it there? It's
what time is it where you are?
Who knows if
should
he's
be
in
bed,
Russia
right?
or Australia or God only
thanks
knows
Amir for joining us again, buddy. We appreciate you being on, man.
He's on the International Space Station. You don't have to worry about him.
Oh, he's fine. So he's okay. Yeah. He's still up for a while then.
And there's a ton of great all of our hip people who are on. I've seen Brian Graham is on here. I've seen several other people. So thank you guys for being on here. But we're gonna let Abby do her quick little case in point. We'll stop pontificating about all of our opinions.
Yeah, thanks, guys. It's super interesting to listen to. I think one part of this paper kind of divided the patients into short and long-term symptoms, and it seemed like 2 years was kind of the cutoff for that. I can recall Dr. Hawkins stating a point in terms of shoulder dislocation back when I was first starting out in terms of, when do we operate on somebody with shoulder instability? Well, it's sometime after their first dislocation, but before their second. And this paper kind of that 2-year cutoff sort of reminded me of that. Okay, we send a patient for a hip preservation, surgical intervention. Does that need to occur before 2 years or after 2 years? And if after 2 years happens, are they going to have worse outcomes than before too? So, just interesting kind of delineation in time. But I've got 3 quick non-operative cases, all with MRI confirmed labral tears. And I kind of picked 3 females, kind of an acute, a mid, and then a longer term diagnoses. My first one, she had symptoms really acutely for 2 days. So she is 6 weeks post a hysterectomy. Interesting that we bring up a lot of like pelvic floor and OBGYN diagnoses. And as well as some hip spine conditions, because all these patients can kind of be like blurred in the realm of, is this pelvic floor, is this spine, is this extra-articular hip, is this intra-articular hip? But she went for a 2-mile jog 6 weeks after her hysterectomy and went to OB, got cleared for activity. Boom, ended up with this like acute glute irritability. Saw pretty quick our local hip specialist, has an MRI confirmed tear, but kind of some differential with her was, hey, do you just have this like irritable glute from this quick return of activity? Do you have this funny lumbar referral? Is your pelvic floor still involved? All of that information in the presence of an MRI confirmed tear. Versus my second case, her symptoms are a little more classic, like 3 to 4 months, not an acute mechanism, more insidious, but worse with things like running, squatting, lunging, deeper flexion positions. Kind of in terms of what other anterior hip structures could be going on. Is this an iliopsoas irritability, hip flexor strain? Whereas my last patient, longer symptoms. So she kind of falls into that 2-year plus category. She's had PT previously. She has seen PCP. She's seen neuro. She's also seen our local hip specialist. So she has seen all of the providers. So she kind of is the person that has seen multiple providers and is now in this like over 2-year symptom duration. Her symptoms were a little bit cloudy in terms of some lumbar contribution because she had some previous lower extremity numbness that has cleared up currently, but symptoms still can be reproduced with some lumbar directed intervention. So for the 3 of them, classically like pain with hip internal rotation. My first girl really had better, like more preserved motion as in terms of the my second patient and my third patient, a little more irritable, a bit more guarded. I think common for all of these patients is they have really crappy glutes. So kind of in between like half to 2/3 of their hip abduction strength, we can compare side to side. There, from a symptom perspective, my first patient was more like crummy feeling and glute med, TFL, kind of some lateral hip soft tissue. My second patient has a lot of like proximal rectus femoris irritability, whereas my third patient, some blurry potential lumbar contributions. She gets some of her symptoms with L3 UPAs, but also can get her familiar hip symptoms with doing like an inferior or posterior joint mobilization. So again, another rabbit hole of hip spine, but totally real. These patients come with lots of different baggage and lots of history. Their patient-reported outcomes are listed, and I think also common theme for all of these patients, they have a hard time really like recruiting their glute without some potential like anterior hip and TFL compensation. So I think that leads to them feeling really just sore in their anterior hip. They have to have a lot of posterior capsule mobility work, some management of soft tissue irritability, whether that be lacrosse ball, foam rolling, dry needling. I think they tend to not do as well with some repeated tensioning and stretching over their anterior hip, as we've kind of seen in some of the conversations you guys had. And maybe us just chronically tensioning their anterior hip over time, potentially thinking they have a hip flexor involvement, is just doing them a disservice. They don't have a motion issue. They've got a soft tissue issue that's just making them feel lousy. But our rehab theme was really progressive glute loading from open chain to closed chain. Lots of work spent with these patients on just how do I figure out how to get my glute to turn on versus my like quad and hamstring or my TFL vastus lateralis, all trying to contribute into making my hip work. And then graded activity return. So quick outcome on these 3 patients. My first patient did well. She had probably the biggest substantial hip strength improvement, best reported outcome improvement. Interestingly, after her hysterectomy, she then went later for a prolapse repair. She had an upcoming hip consult, so still dealing with some of her intra-articular hip issues, but kind of took a back burner to some of her other pelvic floor and OBGYN dysfunction. My second patient has surgery scheduled. She was probably the best example of, hey, let's do a trial of therapy plus injection plus some anti-inflammatories. Let's see how you do. Her and I have met sporadically over the last couple of months, and have been able to make some progress in her hip strength. But really, her motion is lousy. Her daily activities that are uncomfortable are still uncomfortable, and she's got surgery scheduled when it most fits into her work life in the next couple of months. And then the last patient, her and I are still working together. She's made some improvement in her glute strength, some improvement in her hip motion, but she also has an upcoming hip consult, and I think will be another interesting person to discuss with, hey, is it time for us to go down the surgical route, given that we've done this extensive PT, not only currently, but in the past. She's been worked up by multiple providers. But again, kind of approaching that 2-year window of, hey, are my outcomes not going to be as favorable now that she's kind of in this like long-term symptom category as compared to some of my more acute patients. But those are the 3 that I have. I think, great to hear you guys in terms of some differential, some things that have gone well, some things that haven't gone well in your practice. And, I'd be interested, Ashley, if these are some common symptoms and themes that you've seen with some of the patients that you share with Dr. Bird, or even Dr. Christoforetti. Are these some common complaints that you see with patients when they come see you for their consult?
Yeah, I mean, I honestly couldn't have done a better job of putting that like 3 really great examples of like very classic. I mean, we mentioned some outlier type of situations, but like really great examples of like variation of what we see and kind of how those things can play out. So it's funny, like obviously the more you do it, like I was like, oh, patient number 2 is gonna have surgery. Like the moment you put it up, I was like, number 2 is having surgery. So that's awesome. So thank you for sharing that.
And Abigail, I was going to say same thing. Thank you very much. In that you also illustrated a lot of the points that we're talking about, like looking at these things, doing a trial, or looking at things from a broad perspective, and then saying, yep, this one has to go back. This one has to be worked up for their hip more. So on. That was really good illustration of that. Thank you.
I would just say that just for the 300 so plus participants still on, like we didn't do a rehearsal, and we didn't know what we were going to talk about, did we?
No.
And you work with an expert hip surgeon named Jason Folk, who I'll be happy to name. And, you could have done that. That could have been any of the 3 people that I would have seen this week. Yeah. And I feel like what it shows us, Rob, a beautiful design. This is why your thing's like better than Joe Rogan. You point out exactly with those 3 cases. Well, I guess we've done something to learn and grow more than what that paper we reviewed is, because we're up here in DC and you're down there in Greenville, Spartanburg, and they're out in Nashville, and we've all independently come up with the same kind of situation. So I think it probably is a good, reasonable State of the Union on that one.
Yeah.
Awesome.
Yeah.
Good job.
So
Thank
good.
You, Abby.
So good.
Yeah.
Awesome. Well, yes, thank you to the 300 plus people that are still hanging out with us. Of course, one of my favorite conversations, one of my favorite people.
Of course.
But appreciate everyone. And again, just some great overall takeaways, I think, tonight as both therapists and physicians. So thank you to everyone. Thank you, Abby. Thank you, Dr. Christoforetti.
Yep. Thank you.
Thank you.
Let's go USA.
There
you go.
That's right.
That's right.
Get the Olympics in there.
Thank you guys very much.
Everyone. Share
Thank
the
you,
replay.
Doc. Yeah.
All right. Well,
bye, everybody.
See you guys next month. Bye.